Okay, everybody, I think we can get started. Again, this is Neil Andrews, and I am with IASP. I'd like to welcome you to today's webinar to be presented by Kevin Hellman, Sandy Hilton, and Frank Tu, and moderated by Qasim Aziz. The topic for our webinar today is abdominal and pelvic pain. Today's webinar is actually the second in a series of webinars that we've created for the 2018 Global Year for Excellence in Pain Education. Before I introduce our moderator, I just wanted to bring your attention to some information on the slides that you'll see up. So we're glad to have you here for the webinar, and there are some additional ways to participate. So you can submit your questions at any time to us by typing them into the Q&A chat box that you'll see on your screen from Zoom. And you can submit questions at any time. We're also live streaming the event on Facebook. So for those of you out there on Facebook, welcome. And you can share our Facebook Live video on the ISP Facebook page with friends and colleagues. And don't forget to like us on Facebook. You can see the URL there. And you can also do some tweeting if you like at the hashtag GYPainEducation and also at hashtag ISPWebinar. And you can also follow us on Twitter as well at ISP Pain. Next slide, please. Also would like to bring your attention to the World Congress on Pain, which is rapidly approaching. We look forward to seeing you there. If you haven't registered yet, today, or now is the time I should say, we actually have a bunch of programming related to the Global Year at the Congress. So you can see here we have a plenary lecture, there's also a topical workshop, and there are also some special sessions as well, all focused on the Global Year. So there's some great content on there. And again, if you haven't registered yet and you're planning on going, now is the time to register. Some of the sessions are beginning to fill up. So the sooner that you can register, the better. Next slide, please. We have some upcoming Global Year webinars. So you can see the dates. We have one on September 27th on interprofessional pain education, one on October 25th on education. This is focused on older persons with pain. And then also we have a webinar November 15th on pain education in developing countries. So please save the date. Next slide, please. All right, great. So let's move on. I now have the pleasure of introducing our moderator, Qasim Aziz. Professor Aziz is a professor of neurogastroenterology and director of the Wingate Institute of Neurogastroenterology at Queen Mary University of London in the UK. He's also chair of the IASP Abdominal and Pelvic Pain Special Interest Group. His research is aimed at understanding the neurophysiological basis of human brain-gut communication, and he's made many important contributions to the understanding of how gut pain is processed in the brain and how both inflammation and injury to gut nerves and psychological factors can lead to the development of chronic gut pain. Qasim, it's great to have you here. Please go ahead.
Neil, thank you very much indeed, and it's my very great pleasure to introduce Kevin Hellman. He's the assistant professor at the University of Chicago. Dr. Hellman directs a NIH-funded research program on dysmenorrhea, the leading cause of schoolwork absence and foremost risk factor for chronic visceral pain in reproductive age women. His laboratory has developed new animal models, investigated novel diagnostic methods, and conducted treatment studies. His goal is to systematically define the pathophysiology of dysmenorrhea and develop new treatments, while simultaneously training a cadre of future investigators to revolutionize the study of visceral pain. So over to you, Dr. Hellman.
Thank you for the kind introduction, Qasim. It's a pleasure to talk about mechanisms of abdominal and pelvic pain, and we're going to talk a little bit about the background scientific mechanisms, some issues relating to assessment, and Frank Tu, my colleague, will discuss some of the recent applications of our work in dysmenorrhea. I can't go into all the detail of all the abdominal pelvic pain conditions, but I will touch on a few here. So one of the most common ones is dysmenorrhea. That's period pain. It's unclear how many women it actually affects. So at least 50% have some mild symptoms, plus or minus 20%, and maybe 20% of reproductive age women have moderate to severe menstrual pain. In some cases, there is an identifiable anatomical cause. For example, endometriosis. It's very hard to assess this without surgery. As many as 1 in 10 women might have endometriosis, and not everyone who has endometriosis has menstrual pain. A large number of people that have menstrual pain, in short, do not have an anatomical cause, but they have repeated pain on their period that is associated with other pelvic pain conditions. For example, irritable bowel syndrome, it might affect as much as 1 in 6 in the general population, maybe as much as 25 to 30% of people with menstrual pain. So when in irritable bowel syndrome, you might have women that have a bowel pain on their period, but once it starts to occur beyond menses, then you start to think, well, maybe you have a person has irritable bowel syndrome. Another common comorbidity, which is a chronic pelvic pain condition, is dyspareunia, also known as painful sex. It's distinct from vulvodynia, where you have vulvar pain, but it is more comorbid in people with dysmenorrhea, and they also have other pelvic pain conditions, and notably, it's very common in bladder pain syndrome. Now, that affects relatively few people, maybe about 3% of women, probably a comparable amount of men, but it's very often people that have bladder pain syndrome also have dyspareunia. And very often you can't put any of these people into a box. They have many of these pelvic pain conditions, or they just have continuous pelvic pain, and we can't localize the organ, which is going to be an important feature or an important area of discussion of our program today. How can we better localize the organ and understand where the pain is coming from, because it's not always clear. We can use what is known about cutaneous pain to better understand abdominal, pelvic, and visceral pain. So typically, you have stimuli that do not cause pain, and on the other extreme, you have very painful stimuli. So if we were talking about sunburn, all of a sudden, when you have an insult, levels of touch that were ordinarily not painful would start to become painful. And now when you start to apply a painful stimulus, when a person that is sunburned, they report as being extremely painful. So this same paradigm can be also extended to also understand what are the mechanisms in visceral pain. We could call it hypersensitivity, we could call it sensitization. We're interested in what are the mechanisms that responsible for sensitization, and how can we accurately quantify these processes. And we ideally want to have animal models that are parallel to human conditions. So this is some work by Ness, Metcalf, and Gebhardt, where they inflated a balloon. They did colonic distension, and if you do repeated episodes of distension, people will report that the region of pain is larger. And if you measure abdominal muscle activity, there is increased abdominal muscle reflex activity, and if you apply greater levels of pressure, you'll get an even enhanced reflex response. So some of this work was originally shown in animal by Sherrington. It's important that we show this in people as well, because you can't ask animals to fill out a numerical rating scale, a visual analog scale, but if you can look at a reflex to understand what's going on in a visceral pain model. This has allowed the extension of visceral pain research by a large number of people, particularly to study colorectal pain. I apologize, I can't name everybody that has done this work, but a lot of them have used this model, not just for the colon, but to also understand bladder pain as well. So we're going to talk about some of the basic researches and foundations for studying these things. So for irritable bowel syndrome, you can look at mechanical hypersensitivity, and current research might suggest role for the pH, the microbiome, contractility, motility. We're going to talk about bladder pain syndrome. So some people have, you can measure bladder capacity. And again, we'll talk about mechanical hypersensitivity. We'll talk about some application to chronic pelvic pain syndrome, and we're going to discuss some novel applications to methods to studying menstrual pain. So this is work by Howard Mertz. This is 100 people, and roughly, if you apply rectal pressure in people with IBS, so people with irritable bowel syndrome will report pain at a lower mechanical threshold. So this is essentially, you could call it allodynia if it was a cutaneous stimulus. This isn't a typical stimulus, but lower amounts of pressure produce pain in most people with IBS. So you could possibly use this as a metric to identify whether psychological factors or treatments affect mechanical hypersensitivity, and you can also extend this to animal models. So what are the mechanisms responsible for mechanical hypersensitivity and irritable bowel syndrome? It's not completely understood, but this is some work using a smart pill. So if you look at the junction in between the small and large intestine, we find that, and it's not us, this is the work of Farmer et al., that patients with irritable bowel syndrome have a greater drop in pH. And this has been subsequently been repeated by Ringo Kulka et al. In a larger cohort, and they found the same thing, essentially that people with irritable bowel syndrome have lower pH. Given the backdrop of the focus on the microbiome and people that have identified differences in the microbiome, people believe, for the most part, that an alteration in the microbiome could contribute to lower pH, which could contribute to mechanical hypersensitivity. Additional work needs to be done to figure out whether these involve, for example, the vanilloid receptors, which are known to be pH sensitive and contribute to mechanical hypersensitivity. But this kind of basic research in people as well in animals allows us to start to figure out how we can further refine models of visceral pain, not only for irritable bowel syndrome. We'll see that extends to other conditions as well. So one of the downsides about the using colonic distension as a stimulus is it's invasive. So Dr. Frank too modified Lynn Walker's paradigm for looking at water ingestion to produce visceral pain. Instead of looking at the stomach, we measured the volume of the bladder as it naturally filled up. And what you see here is people with painful bladder syndrome. They have lower bladder capacities, and they have more pain when their bladder is at maximum tolerance. And you can see in blue, we have people with chronic pelvic pain. That's because some of the people behave as if they have symptoms of bladder pain syndrome, but notably, they have normal levels of capacity. So the advantage is we have a paradigm that you can use to look at mechanical hypersensitivity as well as mechanical tolerance in painful bladder syndrome, but you don't have to use anything invasive to look at these thresholds. So these things allow us to study mechanisms as well. So what about chronic pelvic pain? So this is more of a practical application of allodynia, hyperalgesia. So if you just do clinical palpation, this is typically what an OB-GYN might do during a visit, you'll notice that there's relatively no pain or low pain in healthy controls, but a large number of people with chronic pelvic pain will find that palpation is extremely painful. So depending on whether you categorize this as a painful or non-painful stimulus, you might categorize this as either allodynia or hyperalgesia, but this is a way of evaluating pain. But you could be more precise. You could measure the exact mechanical threshold at which people report pain. So you might anticipate, well, all these people should have lower mechanical thresholds, but that is not the case. In fact, there's quite a range of mechanical thresholds, and roughly only about a third of people with chronic pain have very low thresholds suggestive of allodynia. But this kind of paradigm provides a foundation for other people to say, okay, what are the mechanisms responsible for chronic pelvic pain? Because it is a multidimensional phenotype that's affected by function. But here you can specifically look at one aspect, what underlies mechanical hyperalgesia, and you might start to wonder, well, maybe is there a specific phenotype that has allodynia in chronic pelvic pain? So it would be nice if this device here, we could use it to inflate the uterus to look at uterine distensions in people, but that's not very nice or feasible. So instead what we do is we use a little squeeze bulb like this to evaluate spontaneous pain. So the nice thing about studying menstrual pain is that it's predictable. You can invite people to participate on a scheduled visit. The problem is people can't always accurately predict when their menses will occur, and people don't want to necessarily come in unmedicated, but we bring in people unmedicated and we ask them to continuously evaluate their spontaneous pain. And every time they have a cramp, they squeeze the bulb. So how do we know what's going on in the uterus? We use 3T MRI to evaluate what is going on in the uterus at the same time that they're instructed to squeeze the bulb every time they have a cramp. So with MRI, we're able to look at what's going on anatomically, and our current research is now focusing on other physiological factors. But I'll give a demonstration of what such activity looks like. What you're looking at here is the uterus. This is the raw image. This is the pseudo color for non-radiologists. And what you're looking at here is the myometrial layer, and you see an increase in the signal intensity. So this movie has been sped up by a factor of 4. These uterine events last roughly 20 seconds. They're these sustained, intense contractions. We only find these people in participants with menstrual pain, and it's only on their menses. We don't observe it in everybody that has menstrual pain, but generally speaking, all of our participants with primary dysmenorrhea, as we've already published, have these myometrial events. So the question is, what is the relationship between these myometrial events, they're spontaneous, and pain report? Now, these myometrial events that you're looking at on this MRI signal, what you're looking at is an increase in the myometrial signal intensity due to the blood exiting the uterine layers. So this is a high pressure contraction. So this is a way of looking at spontaneous mechanical events. So what is the relationship between these spontaneous mechanical events and pain? So this is a figure modified from our published finding, published paper. You see that some people, so what you're looking at is the average change in signal intensity. So this is just a region of interest within the uterus of all patients that have uterine events. And this is the time course. So the time course, it can last up to about 70 seconds. So this is a time-locked view. And so we've synchronized all of these events to this change in signal. So this is a contraction, and you might, as you might anticipate, what's shown in red here, some people actually have pain that is coincident, simultaneous with the contraction. So given that is coincident, it's simultaneous with this change in signal, we think this is a response to the mechanical contraction of the uterus. So basically this is mechanoreceptors responding to the high pressure within the uterus. Notably, some people do not respond immediately. It can take 34 to even 70 seconds to respond. There's a delay, a considerable lag. These events occur these are more than statistically expected. It seems to be a consistent lag. What we think is occurring is there's an ischemic event because there's often a delay in response to ischemic pain. So what we're actually seeing here is not necessarily mechanical hypersensitivity caused by mechanoreceptors, but possibly caused by a response to ischemic pain. We're following on this up on this finding, and we see some people that have response to probably early pressure as well as ischemia. Now, if you recall earlier, I spoke about visceral motor reflexes, and we anticipated we might also see visceral motor reflexes in women with dysmenorrhea. If they repeatedly have episodes of uterine distension, we might anticipate abdominal muscle activity, skeletal muscle activity as well. What was intriguing was that we found that these abdominal muscle events preceded pain reports. So this is a squeeze bulb event that's a participant is having a spontaneous cramp, and we see that there's abdominal muscle activity that actually precedes the report of pain. And what you're looking at here is background EKG activity. So some of these abdominal muscle events are small, but they happen repeatedly. And so if a woman is having a cramp every 2 to 5 minutes and she's repeatedly contracting her skeletal muscle, you might anticipate that it contributes by pain. Now you could and say maybe this is happening by chance. So we had healthy controls squeeze bulbs randomly in a pattern similar to people with menstrual pain, as well as we also looked at people with menstrual pain off their menses, as well as before and after naproxen. And what we see here is we only see these abdominal muscle events consistently precede pain before we give a rescue medication. There's still a lot of work left to be done in all of these areas. The molecules responsible for sensitization. In the case of uterus, we can hypothesize prostaglandin. I showed you some evidence that low pH in the bowel might be a contributing factor. Methods for differentiating the mechanisms underlying phenotypes of visceral pain. Our work only hints at the role of mechanoreceptors versus ischemia. Careful work needs to be done to evaluate whether there's actually a decrease in uterine oxygenation at the time point we identified. And then we've begun to try and clarify which treatments align with phenotypes. So our data suggests that indeed people that have these abdominal muscle events are the people that are most likely to respond to naproxen. But this work could be extended further with the other organs as well as to better understand what alternative treatments and effective treatments we can develop for menstrual pain. At this point, I just want to thank my colleagues for their contribution to our human research models and our research team, and our work is funded by the NIH, in particular the National Institute for Child and Human Development and the National Institute for Digestive and Disorders in the Kidney. Thank you.
Hey, Qasim, you have, please unmute yourself. Okay, great.
Thank you very much, Kevin. That was an excellent lecture. So what our plan is to actually continue with the other two talks and then to have question and answers at the end. So again, Kevin, thank you very much for that very interesting talk. So our next speaker is Sandy Hilton. Sandy is a co-owner of a private physical therapy practice in Chicago and has worked in multiple settings across the US with a neurologic and orthopedic emphasis. Combine these with a focus on pelvic rehabilitation for pain and dysfunction since 1995. She's been a director of programming for the section on women's health of the American Physical Therapy Association since 2012. She teaches at the health professionals and community education classes on returning to function following back and pelvic pain, and has assisted with myofascial release education and co-teaches advanced level male pelvic floor evaluation and treatment. Sandy's clinical interest is in chronic pain with a particular interest in complex pelvic pain disorders in men and women, and she's co-host of Pain, Science and Sensibility, a podcast on the application of research into the clinic. So Sandy, welcome, and I look forward to your talk.
Thank you. Get mine up and loaded for everyone. So welcome, and I'm very pleased to be able to give a little clinical perspective to how we can take the wonderful research that Kevin just gave. I'm particularly interested in how understanding the mechanisms around why someone might hurt and what the phenotype of these individuals might be can translate into clinical practice. I think that fits really well with IASP's education goal this year of getting the research out into the clinicians' hands and ultimately to changing the way that practice is done for the patients themselves that are in pain. That's what I hope to bring a little emphasis towards in this talk. And to that end, when a person with pelvic pain presents at a clinic like mine with physical therapy, or there are counselors and occupational therapists and all array of health professionals out there that are trying to help these people, we don't have tests that you've just shown. We have manual therapy exams. We have an ability to test sensitivity to touch. We can test whether or not someone is sensitive to pressure, not so objectively as the measures that are used in the research, but through subjective questioning and responses. We certainly have some measures like the Q-tip test that have been used in research and in clinics. We also look at how do they move and are there changed movement strategies, and whether or not there is selective control of the muscles, particularly of the pelvic floor, and through the hips and the low back, and what coordination is like. And when we take that clinical assessment with a careful history and an understanding on what medications an individual is on from their physician to try and provide support, then we can use the evidence that's out to try and create a most efficient treatment design. So I love this blend of conversation between here is our clinical evidence of what might be happening as a mechanistic basis for dysmenorrhea, and then what does that translate to for when that individual comes for help, and what tools do we have at our disposal. And I think we need to rely heavily on the research for this, but it provides a problem in that search for what is best, we are also in a search for standardization of what the evaluation looks like. Highlighting a few studies in this talk of work that has been done quite recently to try and get an understanding of how we can best do that. And in this particular paper just recently published, they were looking at what are the different mechanisms that are underpinning theories for assessment in myofascial pelvic floor pain. And that includes women with dysmenorrhea and painful bladder syndrome and vulvodynia or dyspareunia. So the whole larger picture of pelvic pain can fit into understanding how best to assess them. I might be a little different in my love for the fact that we can learn a lot from studies that might look a little negative on first view. In particular here in this study, the authors recommended further development and standardization of a reliable examination because the ways that this is being assessed is so variable across countries and across the world, and even within different systems of education. So we are not yet standardized in how we do an assessment of pelvic floor myofascial pain or functional measures, and we rely really heavily on continued research to be able to get better at that at a clinical level. But I do recommend that we take a look at what is best evidence for what's going to give us good information. We already heard from Kevin about the possibility that it be both either a mechanical or an ischemic driver for what might be happening as driving some of the pain. And that gives us a clue for what we can look at. So clinically speaking, I can assess tissue mobility and I can assess tolerance to touch itself, but also pressure and movement of touch, and use that as a way to know where to go ahead. I'm gonna move a little differently from dyspareunia for a second to go into some vulvodynia studies that have come out recently, looking at what we would do with the people that we find to be in pain. And I need to acknowledge that there is such a large variety of presentations, even within the dysmenorrhea category, but also in vulvodynia and dyspareunia. And the heterogeneity is reflected in how people respond to treatments in the clinic. It can be quite challenging to say, what is our best view? This study by Marilala Pato and her group looked at the different subgroups among women in vulvodynia and found that we don't have an individualized treatment program that's going to work across the board. And this supports what was just presented in the other paper of we are a little bit, have a variety for our assessment. We also have a variety in what we're going to find on the evaluation. And I want this to be an encouraging comment to the people that are looking both at research, but also in the clinical application of it, because we will see some principles hold while we don't see particulars in evaluation. And what do we do with that then in the clinic when we have a wide variety of presentations and we're trying to help this person to get better? Is we can pull on the research and design treatment based on what we have found for tissue mobility and tolerance and movement, and on the perception of pain. So I think that an appropriate individualized treatment design needs to include a balance of both the peripheral drivers, whether that be mechanical pressure sensitivity or ischemia or muscle and movement and connective tissue changes, and also look at the central targets of treatment based on their expectations and beliefs about pain and how they feel about the results of the evaluation. So it truly is a multimodal assessment and treatment design to get started on helping these people experiencing pelvic pain. We're going to base that design on the evaluation of the sensory tolerance and their reports in the physical examination. And it needs to also include patient-specific functional goals. Now, I'm quite aware that we are all three presenters in this here from the United States within a particular healthcare system, but we're talking to a global audience of what works across different systems. And I think that when we, from a clinical perspective, can stay focused on patient-specific functional goals, that helps to translate conversations across those different systems, in that it's not so much what a payer system is going to cover as much as what is the functional limitation that this person in front of me has. And that's the focus that I think is most helpful. When we put that in the context of persistent pelvic pain and what to do with designing our treatment, we need to also take a look at the cultural and religious challenges around pelvic pain, around menses. There are women that I've run across here in the local area and across the states in my history of work, where their cultural and religious background is that when they are on their period, when they're having menstrual cycles, that there are specific rules that they need to follow, some of which can tie into what's happening with the pelvic pain, and those need to be addressed and acknowledged. There's certainly gender-driven challenges as we talk about pelvic issues, and the expanding world of issues around the transgender population. We have sexual function and preference considerations to take in, and of course bowel and bladder function and the crosstalk between the organs and the pelvic muscles and the spinal innervation. We also need to address things like privacy and personal space, and then your own individual organizational practice patterns. So a nice summary to where are we in treating pelvic pain clinically is that our jobs are complex, and it is more than just this person that has a pain response that's challenging, but it also comes with cultural and religious and physiological challenges that make this a little more complex, I think, than treating perhaps pain in another region of the body. It's worth mentioning as we need to then use that to drive a larger emphasis in some areas on getting true multidisciplinary care involved. Working with colleagues, whether you're in the same system or just in a city, where you address people that can help perhaps with cognitive behavioral therapy through psychology or social work, where we can help collaborate and connect with sex counselors and therapists that can help couples recover an intimacy when they have been dealing with pelvic pain. where we can connect with nutritionists and people that can help people onto diets that are going to be more helpful for them. And when we can all work together and communicate about what the goals and thoughts and beliefs of this person are. And I feel that that's best done through a true multidisciplinary approach. And I know that in some areas we're blessed with an abundance of care, like we are here in Chicago, and in others you need to pull this together through perhaps an online team or a multi-city team, but it is good to address all of those concerns. So what does that look like for treatment direction? Well, as I've said, that we don't have a consistent assessment across the evidence, and we don't have consistent inpatient presentation, and we need to be able to do individual assessments to design your treatment based on some principles. Since we have no high level of evidence for one treatment of efficacy or effectiveness, I think that gives us the ability to use what the person likes the best. Patient preference and goals and expectations are one of the ways that we can tell that someone is going to be more likely to benefit from our intervention. Social determinants of health are also required to be addressed in whether or not someone can consistently come for therapy, or whether we need to do some telehealth or other creative ways to get continued care. Emphasize perhaps more self-care for some people to be able to get the consistency that we need to make a difference. Those are other things that we can use to make the evidence that we have for treatment fit the person in front of us, regardless of our particular organizational ability or payment models. Now, I mentioned that there is not one particular technique that is better than another according to the literature, and that I personally feel like that is a positive for us, in that we can use that information. For example, this study that looked at the effectiveness of myofascial release in the treatment of chronic musculoskeletal pain, they found that myofascial release on its own is not sufficient for treatment. And I need to acknowledge that, as that's one of the hot topics in healthcare for treatments for pelvic pain is myofascial work, but the evidence does not support it as a standalone treatment. And one of the criticisms that we can get from clinicians is that no one does standalone treatments, that is done through that biopsychosocial realm. And we may be using myofascial techniques or other manual therapy techniques as a portion of treatment. And that as these studies come out that say this in its individualness does not meet a minimal clinical significance, that gives us even more reason to continue to look for what's going to be most helpful for a person, and be able to acknowledge that there is more than just one technique that can help. There is more than just manual therapy. And yet, as we heard, a mechanical and an ischemic component may be part of this. So we may want to get tissues to move. We also have more research that says that it is perhaps not the trigger point release or manual therapy work that is going to be most helpful for pain relief. And it can be something that is offered continually for patients. So in the clinical world, we have research on one side that is saying, we're not seeing this stand up to the evidence. We have patients coming in and saying, I really have found manual therapy to be helpful for me in the past, and clinicians that are trying to balance one foot on each of those boards of how do I integrate this into the clinic to help someone get better. But again, we're finding that standalone treatment is not efficient for pain. What we do have a little more information on, and more so in the chronic low back pain literature than in pelvic pain literature yet, is that exercise and education can be very helpful. We know that the level of evidence for effectiveness is weak to moderate for modalities. It's moderate for exercise, so a little bit better. And it is most important that it be for movement and exercise of their choice. And this goes back to one of my original points of getting to know what the patient-specific goal is, so that we can get movement and tissue mobility and a changed motor plan and pattern to get back to normal functional activities, which should support the help of healthy tissue and good tolerance to mechanical input and good circulation. So we're using what we have to get people to do as much mobility as they can. Standard graded exposure techniques, as you would find in working with CRPS or chronic low back pain, hold here as far as an exercise progression and a movement progression for someone in pain, whether that be vulvodynia or dyspareunia or problems around menses. It's all going to need to have a larger movement component to it. We start that exercise and mobility with the area and the movement that is most tolerated and possibly least threatening. We need to let people know that it's okay that they're sore and that the movement and the exercise might create muscle soreness, but that is not damaging anything and is not making them worse. We need to make sure that people know that pain doesn't mean tissue damage, but that they can continue to persist and get better. There's a kind of a rule of thumb of limiting that increase in pain to no more than 2 over 10 of the initial pain state, so that it's a pushing a small load to make a difference, but not such a large load that they're going to be in pain forever. And that portion of the beginning of treatment can be challenging. I think another really important piece to how do we get someone in pain to get out of pain is to also remember that while pain is aversive and it changes our behaviors, we also have pleasure, and pleasure is rewarding. We can purposefully have people do pleasurable input, which can go a long way to changing an assumption on a person that they will always hurt when they move or it will always hurt when they're touched, is to have them practice short pleasurable input. The research on chronic regional pain syndrome says to do that throughout the day, so I have just adapted that for pelvic treatment. And then asking a person what it is that they like to do and helping them get back to that. We developed a set of cards of specific activities for pelvic application of people sitting or in clothes that might be tight, or activities that are usually associated with movement that people in pelvic pain avoid, and can use those photos to get people to help generate what their specific goals are or what their concerns are to develop a movement plan that fits them directly. In the future directions for how to help a person in pain come back out of it through exercise and activity and physical assistance, I think that we need to continue to look at the quality of life questionnaires. There's a women's pelvic pain quality of life questionnaire that Jane Chalmers did, and her group is working on developing a male questionnaire. We are in process here through the American Physical Therapy Association and the section on women's health and the orthopedic section for developing a clinical practice guideline for chronic pelvic pain. That's myself, Meryl Apolado, and Mark Bishop, with a great team of interdisciplinary and international researchers. There's continued work from the MAP program of looking at phenotyping efforts that can help guide us in understanding and recognizing patterns and effective treatment. And we also need to continue to push for looking at the interventions following gender reassignment surgeries, as this is an evolving area of practice that has very little information on how best to help any needs that are identified in that community. So I think we have a lot of very interesting things going on, and that the research can be applied into a clinical practice. And I just encourage all the clinicians out there to not get discouraged when it looks like the research is coming out negative. That actually helps us to refine where we go with treatment. And I'll give a plug for the World Congress, because I think it's a fantastic place for clinicians to go learn and move their practice forward. So my particular acknowledgements are the researchers around the planet that have helped me to keep up to date and are doing really good work, and just keep it all motivated to try and do the best for our patients. Thank you very much.
Thank you, Sandy. That was an excellent talk. Really enjoyed that. So we move on now to our third speaker, Frank Tu, who's a Division Director for shows minimally invasive surgery program in dermatology, and clinical associate professor at the University of Chicago. And as a board-certified dermatologist specializing in pain management and minimally invasive surgery, he's particularly interested in modifiable tests, including perioperative pain. And Dr. Tu directs of research.
Thanks, Qasim. Let me just pull up the slides here.
Okay.
Kevin, can you see them? Are the slides up?
Yeah.
They're not up yet. 1 second. Qasim, is my screen being shown yet?
No, not yet. No.
Share.
I'm on that. I'm not sure why it's not. Let me go back here. Share screen. Great. Desktop one.
There we go. Yeah, you can see your screen.
Okay, outstanding. One last thing. Can I hide this right here? There we go. Good. Okay, great. Well, it's a pleasure to be here along with two of my colleagues here in Chicago. And I want to thank the IASP for giving us an opportunity to present here in this important area of abdominal, pelvic pain, visceral pain as well. So I'll get a chance to extend off of what Dr. Hellman and Dr. Hilton have talked about here, looking particularly at trying to look at the research underlying where we might be able to make inroads in understanding how episodic pain turns into chronic pelvic pain. And our particular focus in our lab, as Dr. Hellman has already pointed out, is on uterine pain, as we're a gynecological unit. So I think it's actually helpful to start by looking at some of the work that's been done, probably most prominently in the bowel literature. When you look at studies that have been done, a number of investigators have identified there's some key factors that underlie the development of functional bowel disorders, such as IBS. Obviously, a number of people will develop these in the setting of having acute enteritis of some sort. And it seems to be that probably increases the odds of having subsequent diagnosis of IBS by about 6-fold. And there's obviously a significant interest as well in issues related to the underlying gut microbiome, such that studies done in Olmsted County, Minnesota, recent exposure, antibiotic exposure seems to increase your probability of getting irritable bowel syndrome, also about 2-fold. It's also important to know that, like the other chronic overlapping pain conditions, that there's a lot of other factors in the biopsychosocial model that are implicated that clinicians probably need to do a better job of addressing. A large-scale study by Nicol and colleagues out of the United Kingdom in a prospective incidence study identified that 80% of all new IBS diagnoses within a 15-month period could be identified within groups that scored higher on scales for anxiety, sleep problems, somatic symptoms, and illness behavior. As a specialty service here, I realize that all too often we don't routinely look for these in patients who are not coming to see us, and we don't also warn them that these may convey risks. No different than a woman's hormonal exposure might put her at future risk for, say, breast cancer or uterine cancer. I think it's incumbent that we start thinking more with that sort of a mindset. And sort of build off of the irritable bowel syndrome literature, you can see here that in this model of visceral pain development that comes from the Rome-3 group, our ultimate emergence of a clinical visceral pain state or the adjacent comorbidities really does rely on an awareness of potentially initial risk factors that may be present early on, such as pain in infancy or the presence of persistent stress, or certainly influences in terms of the endogenous underlying microbiome. And then this, unfortunately, then being triggered subsequently due to acute psychological stress or actual acute trauma, it is this that ultimately leads to the expression of the clinical state. But where we need to probably focus more is understanding how can we characterize the individuals at the left side of the diagram, aka the person who is considerably vulnerable. So let's look at a couple of different pelvic pain states. When we look at the classic irritable bowel syndrome analog in the bladder, interstitial cystitis, bladder pain syndrome, although there has been substantial work by MAP and other networks looking at the risk factors, we still have more to understand. There is some association, for example, with having an incident urinary tract infection, but that only accounts for about roughly a sixth or third of cases. There's been a lot of work by John Warren's group out of Maryland identifying that there's a significant role for functional somatic syndromes in this group, and In the more recent studies out of MAP, they have identified that within the research network, about 50% of individuals, and it can be even as high as 80% in some especially referral clinics, there'll be evidence of a comorbid pain syndrome as well. If you call it an FSS or a COPC, it sort of taps into the same idea. There's some sort of common pain sensitivity. Warren's group has also identified that for women, certainly there is an association with having dysmenorrhea, having a diagnosis previously of endometriosis, and in general that the use of non-contraceptive hormones might suggest that there's an even large group of patients out there who may have other pelvic disorders that they're using medications for, and that those somehow convey risk as well. And I think that'll tap into later parts of this discussion. And there's also been work by Ken Peters' group out of Detroit, but several other groups, including some studying men out of Seattle earlier, including Diane Hetrick, identified that there's some probably cross-organ or somatovisceral convergence that leads to some incident cases of ICVPS, starting with pelvic floor dysfunction. And the work by physical therapists like Sandy and many of our other colleagues really, I think, has transformed the care of many of these patients. What was previously viewed to be a bladder-centric condition now is viewed as sort of a problem with the combined bladder-pelvic floor unit. And I think has allowed us to be very aggressive in reducing some of the suffering much earlier and even prevent some cases from becoming full-blown, such as in the postpartum state. When you look at the broader category of non-cyclic chronic pelvic pain, a nice systematic review by Lathe and colleagues out of the United Kingdom has shown that, again, many of the similar biopsychosocial factors do appear to be relevant. Some of these have relatively modest risk ratios in the roughly 1 to 3 range. But if you look at some of the more common elements we see among the other COPCs, pelvic inflammatory disease history conveys a 6-fold risk. Prior C-section as a surgical trauma conveys about a 3-fold risk. And having a number of psychosomatic or heightened somatic complaint syndromes in a number of smaller studies suggest that a risk that approaches almost 10 for the odds ratio. But what was surprising to us is that despite the study being done very comprehensively, there really was no mention of dysmenorrhea, partly due to the fact that I think the authors themselves tried to look at dysmenorrhea as an actual outcome. And we think that if we look at a developmental course or a trajectory course strategy for looking at chronic pelvic pain, it makes sense to look at dysmenorrhea as an actual risk factor for the chronic state, even though it in and of itself is also worth the study. And so in this slide here, it's one of the more important studies that I've ever encountered, done by Karina Zondervan's group, actually out of the UK, and they've done a lot of work actually on the genetics of endometriosis. That's one of their primary focuses right now. But in this study that was done out of a large postal survey in the United Kingdom, I think what is important to highlight here is in this large-scale study of women, 1,600 plus, that over 80% of the women that you see on the right upper corner of this universe of patients, almost 80% of the patients that were identified as having chronic pelvic pain by self-report also reported having painful periods, which is the area in pink. And it suggests that we have a tremendous opportunity that since dysmenorrhea is identified early, that if we are really trying to think about how to look at episodic pain versus chronic pain, looking at the episodic pain cases early would potentially get us to look at essentially most patients that would later on develop chronic pain. This is not sufficient by itself, of course, because there's a relatively poor specificity. If you were to try to study all of these individuals, this group of individuals in pink represents almost a third of all patients with painful periods. So that would be a very large group to attempt to mount an inception cohort study on. Given that, we turned our attention to work that had been done actually in the pediatric literature as we thought about how to better refine the study of painful periods. And work highlighted by this review here from McKillop and Benez in this area has been done by multiple teams, but particularly by our collaborator Lynn Walker at Vanderbilt. And it was a rather eye-opening experience to start looking at the pediatric literature. Many of you in the audience will be familiar with the GI literature because that's your home. But for those of us in gynecology, we are not as apt to look at intrapersonal or interpersonal factors. These have been identified in multiple studies as important factors for why a child might get the emergence of functional abdominal pain, which is their sort of chronic pelvic pain analog prior to adulthood. And this has been shown in several studies to underlie both the acute to chronic pain transition as well as the actual maintenance of chronic pain. But these are key factors that I think that when we take the time to ask adults about in the clinical setting, that it's very easy to ask about things such as anxiety, depression, acute ongoing stress, but probably even more so to look at the prior history. So looking at parenting styles in terms of communication about pain, looking at the family environment. I'm reminded of a recent patient I just saw who described an incredibly disruptive childhood, which I only got a minor window into. When I called the PCP up and talked to her, she said that the family had multiple foster children in there, and that the norm in that sort of environment would have been total chaos, and that the fact that the child was doing as well as she was at 18 was really a remark of resilience. But it was also the reason why she also is probably exhibiting 5 separate COPCs even at the early age that she's at. So there's some real important opportunities here if we are willing to listen to talk to our patients and talk to particularly our pediatric colleagues about how best to assess for this vulnerability. And if you think about this at the left side of the original screen we look at for the progression of visceral pain, we can see here that there's probably a real opportunity to identify vulnerable individuals much earlier if we're much more systematic in gathering this data. And in terms of education, which I know Sandy has been very, very passionate about making sure that we do a better job of explaining to patients about why their sensory systems work the way that they do. I think that many patients confronted with this sort of information are actually rather gratified to understand that what perhaps has appeared to be dismissed by prior clinicians is really more of a reflection of the fact that we have such a poor understanding systematically about how these things weigh on an individual as they are in adulthood having sensory disorders such as pain. So in a study done by Mulvaney and colleagues out of Walker's lab, which just comes from 2006, I think this actually is highlighted very nicely. They took young kids between 6 and 18, about 130 of them, and followed the course of some of their clinical outcomes when they had a diagnosis of functional abdominal pain. The strength of the study is that they were using a validated instrument, the childhood somatization inventory, as well as a functional disability inventory, and they repeatedly administered this over 5 years, which is a very, very remarkable study to pull off. And what they were able to find, which was eye-opening for us, was the idea that using trajectory analysis that the groups do segregate. As we expect as clinicians, certainly there's some groups that only come into the clinic because they need some reassurance and get better. And there's a low-risk trajectory group. But what's interesting is to look at the short-term and long-term risk trajectory groups, which I'll show in the next slide here. If you look on the right, they're using the childhood somatization inventory score here on the top y-axis. And the higher the score is, the worse a person's total number of bodily complaints are. This is essentially a measure of somatic sensitivity. And as I mentioned earlier, at the bottom of the screen here, you can see that the vast majority of individuals, probably roughly 3 out of 4 in this lab, start with not a lot of somatic sensitivity and stay that way. And this also mirrors their functional disability inventory scores, indicating that these individuals come in with some sort of abdominal pain, but its overall impact on their health stays low and continues to be low 5 years later. But if you look at the start points for the other two, which is the remaining 30% of the individuals, it's really intriguing to see that there's one group that starts high and then quickly plummets down in terms of their total somatic sensitivity. And although seems to have some tendency to go up later in life, still stays relatively low with a CSI score in the 20s. It's this 15% here that you see at the highest top tier, which never seems to recover, that is, I think, of significant interest to us, because this group here that has the long-term risk, you can see, has both heightened somatic sensitivity and also significant depression and anxiety. And it suggests that if we're really going to start to define studies of who has episodic pain states that is likely going to have the emergence of chronic pain, we do well to start by looking at people who have exhibited significant somatic sensitivity, also have comorbid mood disorders, and if you go back to our original premise, and probably have some degree of complaint of painful periods, which is a factor we can identify perhaps as early as age 13. So our search for looking at these preventable risk factors in the clinic led us to look not only beyond these sort of clinical questionnaires, but also to start saying, are there objective measures that would allow us to limit some of the bias that might be implicit in some of these questionnaires? Patients who have been in an environment where it's encouraged to talk about somatic awareness may inherently score higher on those questionnaires, as we alluded to. It's all part of the intrapersonal aspects of pain. So we turned to the literature and looked at what has been done previously for provocative experimental measures of visceral pain sensitivity. Some people have used bladder infusions of potassium chloride, which can be extremely irritating for people who already have chronic pain. It's not, unfortunately, a selective test for bladder pain syndrome. It's also fallen out of disfavor because it's quite uncomfortable. Some people in Chicago out of Loyola have in the past done electrical stimulation, but again, it's a very unwieldy measure, not something that would ever be adopted in widespread ambulatory settings. And of course, the canonical studies done in irritable bowel syndrome have relied on colorectal distension, and to some degree are used in the gastrointestinal clinic. But for doing large-scale population studies, has obviously some limitations because of the need to place a balloon retrograde up the anus. Nevertheless, it's impressive the amount of work that's been done even in pediatric populations using this methodology. But we thought that if our goal was to look at long-term studies, we'd need simpler, less invasive methods. So in work that we were doing on our career development award back in the late 2000s, we got feedback from some patient groups that a non-invasive test to provoke bladder filling might be highly desirable if we wanted to test patients who already had full-blown visceral pain states. And so we simply relied, as you can see in this diagram, on getting individuals to aggressively hydrate in a safe way, and then attempt to follow their change in pain state as they perceived it related to their bladder, as their bladder filled up until it reached maximum capacity. The assay is very simple and could technically be done at home. In order to achieve some validity and ensure that there was not some confounding by volume, we use bedside ultrasound to attempt to measure bladder volumes at the same time. And initial results from this were published in the Clinical Journal of Pain back in 2013. This is not the fastest of tests. It can be done over the course of about 2 hours, but the vast majority of patients will actually reach completion in about 1 hour and 15 minutes. And it's obviously very well tolerated, even in patients who have a history of bladder pain, because it entirely mimics everyday activity. And you can see right here an example of how we can do 3D rendering with pretty much most available ultrasounds to get an actual volume measurement. This volunteer here had about 450 cc's in her bladder by the time she reached maximum capacity. So we did the initial validation on this work, and very grateful that Kevin Hellman came to our lab right at the time when we were doing some of that key work. And when we took some of that preliminary data and looked at it a little bit further, in this paper here was published recently in the British Journal of Obstetrics and Gynecology, you just focus mainly on the right side of the figure. You can see that the groups here, which are black being healthy, pain-free, blue for what we use as a positive control, chronic pelvic pain patients, and then red being individuals who had a full-blown diagnosis of interstitial cystitis, bladder pain syndrome, that the pain scores on the x-axis are most significant and diverge very early on from health controls and even from the chronic pelvic pain without a formal bladder diagnosis cohort. And this indicates that there's an evidence for visceral hypersensitivity, as you would expect in bladder pain patients, but this was part of the key validation. Even more interestingly, there's evidence of this to some degree in the chronic pelvic pain patients. If you look at the blue, they're just not nearly as pronounced. There's some degree of a volume restriction in these individuals, not surprisingly, and it may be more likely that's driven by pain, but for some patients it may be more of a sensory urgency. So we also did some additional work to ensure that this initial group of about 70 individuals weren't just giving us some random data. So the reliability measures that we have posted here show that repeat testing of these individuals shows similar levels of pain with filling when we did a second round of testing within a few weeks. What's interesting is that if you look at the third column here, there was a group of individuals we found that we call DCOS, or cross-organ sensitized. It's individuals who have painful periods. This was a validation study, so this was largely young, healthy women. But these women, unbeknownst to us, who did tell us their dysmenorrhea status incidentally, also scored markedly higher on bladder filling than we would have expected. You can see the scores here approach a severe range. And what's even more interesting is if you contrast their results with this group of people with a fully diagnosed interstitial cystitis picture, they have pain scores that are as bad, if not worse, than those individuals that have a clinical diagnosis. So this is more about the validity and reliability of the measures, but also to point out that this can identify a potential risk group that doesn't even know they have bladder issues. They may have thought this themselves, but this is a way of experimentally confirming that. And so in studies that we've published recently in the Gray Journal, Dr. Hellman was the first author, we were able to take a group stepping back and say, so among people with just painful periods, how much evidence is there for cross-organ sensitization? In other words, a group that might, for example, be vulnerable to development of chronic bladder pain later on, or a chronic visceral pain state in general. And I think it's important to note that at each of these different levels of volume, we show that there are differences in the report of pain between the dysmenorrhea individuals and the healthy controls. These are roughly age-matched individuals. There's no other thing that would really explain these group differences. But and admittedly, the pain scores are not terrible, fortunately, but it is nevertheless a pretty substantial difference at maximum tolerance to see the group difference of 25 out of 100 for bladder pain on routine filling compared to healthy controls. One might say, well, perhaps this is nevertheless contaminated by an individual's mood state, but in multivariate analysis accounting for depression and anxiety, these relationships remain robust. When you look at it, just parse that a little bit differently, and this becomes important if we're going to talk about eventually screening. We can see that a full maybe 20+% of the individuals on the right side of the graph in red, who are in that dysmenorrhea category, will exhibit some sort of significant bladder pain with this simple testing, and it suggests that looking at them would likely at least yield a trove of individuals that might be able to be more carefully phenotyped to see if they're at future risk for developing pain issues. In contrast, if you look at the blue and the healthy controls, there's hopefully a relatively good specificity here. There will be some inevitably in the healthy group that for some reason have bladder issues that may also be important. But it just goes to show that as a first winnowing mark, dysmenorrhea could be an excellent place to start with. And further, this experimental measure that, again, is non-invasive and should be readily adaptable in the ambulatory setting does seem to be consistent when you look at other measures. So while we do this as a formal 2-hour test that's done in a controlled setting, we have some patients who just walk in the door and do what we call a rapid bladder test. They've already kind of gotten primed to come drinking before they walk in. We don't observe the initial diuresis, but rather we say, when you get to first urge, tell us how your pain score is. And again, you can see that there are individuals with dysmenorrhea who obviously have higher pain scores, and there's a group that who report pain at filling, and that they're obviously having pain on their rapid bladder test that's even more pronounced. We see similar results, alluding to what Sandy was talking about the standardized clinical exam. When we do a standard clinical palpation of the bladder, we see higher pain scores, specifically in that group of individuals that have this cross-organ sensitized phenotype on the formal testing. And we see the same thing again on their actual home bladder diaries, asking them just to report their spontaneous bladder pain across the month. So this measure does seem to at least have some initial validity that it could be used to look at the broader population as a measure of potential visceral sensitivity. So to conclude this part of the talk, I think it's important to state that we found in dysmenorrhea, there are some women who seem to have higher levels of bladder pain, and that's not driven simply by biases by mood or attention, and that this is a measure that seems to be consistent when you measure it several different methods. We would suggest that this sort of non-invasive bladder provocation testing might form one of the key tools used if we're going to start looking more carefully at which individuals with episodic pelvic pain are at risk of developing into chronic pelvic pain. And hopefully of the tools we described here, they all might be things we can already start to apply in routine clinical settings. I'd want to thank, as Dr. Hellman has already, our funding sources through the NIH, both at NICHD and NIDDK.
Frank, thank you. Thank you very much indeed. Excellent lecture. We have quite a few questions, and if other attendees would like to ask some questions, please add them to your chat room. Perhaps we can just start by a question from Arena Riker to Kevin. Did the responses for the immediate, delayed, and mixed correlate with clinical features of CCP? So is there a clinical correlation? Kevin, I think you need to unmute.
Yes. So there is not a relationship, because the people with endometriosis highly represent the chronic pelvic pain group, and in fact, they tend to not have uterine contractions at all. So one possibility is it is not the uterine contractions that are causing pain in people with endometriosis. We're still trying to figure out what's the difference between the ischemic and the mixed and the immediate mechanical group. We're using other physiological methods, but it's, I'd say the abdominal muscle activity, in fact, is what distinguishes the chronic pelvic pain from the primary dysmenorrhea. The people with primary dysmenorrhea tend to have these abdominal muscle events. The chronic pelvic pain patients are less likely to have abdominal muscle activity before self-reported cramp.
Okay, thank you, Kevin. There's another question about whether there are questionnaires that can be used to assess distinct mechanisms in pelvic pain. So, do we have questionnaires that will tease out whether this is more like neuropathic pain, myofascial pain, etc.? So,
he wants to know if there's questionnaires that can be used for chronic pelvic pain. You're not muted. You're off. You're live. You're on mute. You're live.
Okay, great. If you look at pelvicpain.org, there are. Hold on one second.
Yeah.
You got it? Okay, good. Yeah, there are a number of questionnaires if you wanted to go look for them that you could get your hands on, but pelvicpain.org, which is International Pelvic Pain Society's website, does have a questionnaire that can be used for clinical assessment. It covers a variety of things like probably a McGill pain descriptor, gets comprehensive questioning about bladder, bowel, pain with intercourse, generalized pelvic pain, pain with menses, that I think is an excellent place to start. And I would say that for almost all the patients that we see, we'd want to have those four areas: bowel, bladder, pain with intercourse, pain with menses assessed in women, and obviously in men, we'd probably want to get similarly pain with intercourse, pain with bowel movements as well. It's definitely good to be thinking cross-modal with these patients, no matter which clinic you're in.
Okay, thank you, Frank. So there's another question from Luciana Bahia for Kevin. Regarding neuropathic mechanisms, are there imaging studies or pelvic fMRI studies can help to describe nerve involvement, reinforcing evidence of neuropathic component in some of these patients with CPP? So is it possible to actually diagnose from those who have hyperalgesia, mechanical hypersensitivity, which ones may actually have true neuropathic pain?
To answer the question, so first it has to be established what is the threshold for neuropathic pain. A lot of healthy people, participants, do report above. Frank, your mic or your speaker off. All right. A lot of healthy participants have pelvic pain, allodynia, hypersensitivity, but are there methods, nevertheless, to see with imaging underlying mechanisms? And recently, it's not by us, but you can use diffusion-weighted imaging potentially to look at abnormal innervation in the uterus, but additional work needs to be done to evaluate the peripheral nerves as well as the innervation of the uterus, the bladder. A lot more work needs to be done. We're just looking at brief physiological states, not yet at the innervation.
There's no physiological test at the moment which will differentiate between.
Not yet.
Frank, does bladder pain stop when the menopause is reached in case of these patients with dysmenorrhea?
Unfortunately, I think if you look at that diagram for visceral pain that we borrowed from Rome 3, the risk factor and the trigger oftentimes can be eliminated in many of these states, right? The infection, the acute trauma of cesarean section, maybe just a traumatic sexual experience. Even something as routine as a single colonoscopy or a woman getting like a laser hair removal. Once that thing's gone, these patients will report pain for years afterwards. So I would view that the painful periods are potentially the kindling for this bladder pain vulnerability rather than being something that is maintaining that state. Fortunately, I think there are exceptions. And we certainly had a few patients who might have had even decades of painful periods and struggled to control them, who have some other pain states that when they reach menopause, everything just magically clears up. And I think that's certainly part of the challenge that we have to explore is like, what keeps an individual from having an intact central processing of pain despite having recurrent, persistent peripheral activation of the nervous system?
Okay, thank you. Sandy, if I may actually ask you, you mentioned about the myofascial pain and various manual treatments for this and so on.
Right.
I've actually seen some of these patients get pelvic Botox injections sometimes, and pelvic floor Botox injections. Some of our patients actually find them incredibly helpful when I'm talking in my interaction with my colleagues in urogynecology, for instance, who use this sort of technique. Is there any evidence behind that for use of injection therapy, particularly Botox, etc.?
For Botox into the pelvic floor muscles?
Pelvic floor muscles, yes.
There is, Frank might know this better as someone who does it, but there is, no, I'm sorry, the echo's bothering me. There isn't any strong evidence for it, but there are certainly people who clinically get progress from it. So I guess I put that in the same category as we don't have strong evidence for manual therapy, but there are people who say that that helped them get better. We don't have strong evidence for Botox injections, but there are certainly people who have gotten better from them. So makes me very curious about what the mechanism of relief is, since we're not able to really prove it in studies, or at least it's not showing well in studies. But people certainly have gotten better. It doesn't seem to have a negative effect. It either helps or it doesn't.
Okay, that's helpful. But it seems that there is a need for quite deep phenotyping in these patients to see what the mechanisms are and how they may respond to therapy, and there is a gap.
Yes.
And I suppose there is a study in Oxford and EU-funded study at the moment. Katie Vincent is leading that may help to identify some of these subgroups.
Yeah, and we need some good blinded studies to rule out some of the other contributing effects too. Hard to blind some of these things.
Yeah, okay. Perhaps we can take one final question. Richard Dobson has actually made an interesting observation that the EMG of the visceral muscle cramping that you showed, Kevin, the discharges look very similar like myocardial signals rather than background striated muscle activity. So he's queried whether it was just regular electrical discharge of striated motor units and why it may indicate an unusual pattern of, or maybe it was fasciculations. So you found that a little bit unusual. Any thoughts on that?
Yeah, so what you're seeing, what you saw in that figure, there's an abdominal muscle event. It's a published figure already. And you're looking at heartbeat artifact in the background. So the initial event is largely compromised, potentially of movement artifact. It's not the cleanest signal because it is fatty midline region. It's really hard to get a good abdominal muscle recording. However, what's not included is we did simultaneous ultrasound measurement of the abdominal muscle, and we see on ultrasound the abdominal muscle activity preceding the pain report. And I think the combination of that, as well as we're actually able to predict, we saw right in the room real time that we'd see these events right before they had the pain. We analyze it in a blinded way. Very often there is EKG artifact, but we've seen in a couple different methods that there is abdominal muscle activity, and the electrical record may not be clean due to confounding of movement artifact as well as the consistent background activity.
Okay. Well, I'd just like to thank all our speakers for their excellent talk, and all of you who have participated in this webinar. Thank you very much for your presence today. I'll also take this opportunity to thank Neil Andrews and Michelle for helping to organize this webinar today. Thank you very much, everyone. And,
Thank you, Qasim. If I can just jump in here at the end. I'd also like to thank Kevin and Sandy and Frank for really fantastic talks today, and for really taking the time to put together this great selection of talks for the Global Year. So thank you so much. And Qasim, I'd also like to thank you, of course, for moderating the discussion and all the audience questions. And of course, we thank all of our attendees for listening to the webinar and for submitting your questions. A final note, we'll have a recording of the webinar on our Facebook live stream available. So if you'd like a replay, or if you have colleagues who might like to listen but weren't able to attend, you'll be able to access a recording on the ISP Facebook page. And it will also be posted on the ISP website as well. And also, I just wanted to bring your attention to the slide. For more information on the 2018 Global Year, you can head to the ISP website, isp-pain.org/global year. And again, you can follow the conversation #GY Pain Education on Twitter. And we encourage you, if you're not already a member, to join the ISP Abdominal and Pelvic SIG, and you can see the URL there. So again, thanks everybody, to the speakers and our moderator and our attendees. We really enjoyed seeing you here. Thanks for attending, and we look forward to seeing you at the next one. Take care, everyone. Bye-bye.